Thank you very much, everybody, for being here today, and those of you who are online. I thought I would speak about the experience of pain in adults with sickle cell disease. And it's something that we obviously think about a lot with sickle cell because pain is one of the main features of our patients. And we've all been hearing about the APPG report and the importance of rapid analgesia for our patients within 30 minutes of arriving in A&E. And I've been speaking to a lot of patients. I'm involved in a group of patients based across the UK, really, who are trying to think about different and better ways of coping with pain and dealing with pain and explaining pain to their doctors. And I thought I would sort of focus on that because it's probably not the kind of presentation you'll be used to hearing, but give me a chance and we'll see what you think. So obviously I haven't got sickle cell, and so I don't know what it's like to have sickle cell pain, and there's no way that I could even imagine what it's like to have sickle cell. So the first thing to say about living with pain is that we don't know what it's like to live with pain. And so the only people who can really tell us what it's like to live with pain is our patients. And there's lots of different ways of finding out what your patients think. And to a certain extent, having your patients tell you when they're in pain, what it's like, is there's that power imbalance, isn't there? Because the patient actually wants you to give them painkillers. And so you're not sure whether what they're telling you is exactly what they're feeling or what they're telling you is what they think you want to hear so that you give them the medication. So whatever the patients are saying is what we should believe, but it's also important to have that discussion with them. And lots of different people with sickle cell have found different ways of trying to explain that pain. And so I've picked a few artists who have done some really important representations of pain, and this is one of my favorite ones. His name is Hertz. Actually, he died 2 or 3 years ago of a complication of sickle cell. He's an American artist, and for me, this is one of the most famous ones as well. I'm sure everybody's seen it. And there's also a young lady who has done a lot of other paintings of what it's like to have sickle cell, and again, it's they're quite violent paintings, aren't they? And they express the distress and the horrible feeling that comes with that pain. These are other things I found on the web. I don't know the names of the artists, but I thought we can see that facial expression of sort of being vulnerable to all of this and being sort of almost drowning in all this pain. Just got the face left that can breathe. And then this one was this young man and the snake, you can see sickle cell, but also like the snake is weaving in and out of you. A couple of other ones here, something with blood transfusions. This one is maybe less talking about acute pain, but more what it's like to live your whole life and what it makes you feel about yourself. I've put in a few quotes as well, again, that I found on the web. It feels like being stabbed repeatedly while having a migraine throughout your whole body. Feels like multiple fractures and broken bones and glass flowing through my body. For me, it's like taking a rubber band and tying it on your finger over and over again until you can't anymore. Leave it for a few minutes, take scissors and snap that rubber band. Now imagine that stabbing pain you will feel on that finger for a split second, stays on your joints non-stop until, of course, the painkiller kicks in. Sometimes it's like nails being twisted into my joints, but other times I can feel it coming and the cluster of it only in certain areas.
Noemi, I'm sorry, I think the slides for some reason are not moving for the folks that's in the ether, so we'll just have to have a little we can do. Stop sharing and we'll start again and see if that helps. Sorry,
that's okay. Can you see it? Can you see it now?
Yep, that one has come up. Change the slide. Yes, it moves. Sorry,
it's not changing.
It's not moving?
No, it's almost like you've just shared that one.
Oh, okay.
Yeah.
Okay.
Yeah.
No, wrong one. Go to the right.
work?
Is it sharing now?
The sharing is paused.
If we stop presenting, is that going to? No.
Okay.
Right.
I don't think I
It
can
doesn't like when it goes
on slideshow,
I
yeah.
don't know why.
If that doesn't work, we'll go to non-full screen. Okay. No?
No, no.
Okay, so let's come out of slideshow. Now is it sharing? No. Okay. Yes? Yeah. Okay. So I'm going to keep it like this.
Sorry.
So to describe the most prominent pain, it's an electric shock. It's to your heartbeat that comes in waves. Sometimes the pain can instantly change from where it is. Example from your right arm to your left leg for other pain. It can feel like your limb is being suffocated and has a throbbing sensation. I battled all day. I battled joint pain all day, like sharp teeth biting at my knuckles, elbows, my ears and toes. My legs feel like steel rods and have been inserted and were too heavy to maneuver. I was listless and lethargic. If you've ever crushed the tip of a finger on a door, if you've ever kicked the corner on the wall barefoot with your little toe, you may have an idea what I feel, with the difference that the intensity of our pain is too worse in several parts of the body at once, and it doesn't go away for a while. I just feel like the pain is always there. Some days it's 4 out of 5, and some days it's 9 out of 10. Well, the pain can't really be described at its fullest, but there's always that feeling that you're being poked or stabbed by little pointy iron nails. So my point about showing you these pictures and showing you these quotes is that to show that there's that intensity of pain, that severity, the fact that it moves around and that it doesn't make biological sense, and that we can't say you've got pain here because there's vaso-occlusion here and that's why that pain is coming here, and how individual it is. So it seems patients actually really hate our 1 to 10 saying what's the pain like now, and we like that because we want to give them medication and we want to say, oh excellent, it was a 9, now it's a 7, we're going on the right track. But patients don't like it at all, and the feedback that I'm getting from this pain group I'm involved in is that they're only engaging with it because that is what we want and that is what we want them to do. So I personally feel we should try to move away from that. But also you can see from that variability of how people find pain and how variable it is within those areas, that it's not that helpful to try and use this kind of one-size-fits-all scale. So what I wanted to talk about today is this thing about pain and strength, and talking about chronic pain and why do we have chronic pain. And what I'm showing is from this really bizarre little book I came across on Amazon as I was searching for where I get them. And I thought people would be happy if there's something a little more scientific, which is one of the ASH education sessions, optimizing the management of sickle cell disease in chronic pain and sickle cell disease. And actually, I also have that new textbook about sickle cell disease, which is actually saying all the same things as that funny little book I showed you in just more detail and makes it more scientific. So obviously, we know that pain is a moment when your brain decides that something is unsafe and you need to do about it. And for most of us, pain is all about there's a dangerous stimulus that we feel, and then there's a message that goes to our brain to say, this is dangerous, you need to move away from it. And therefore, for most of us, a small amount of damage will basically cause us a small amount of pain. A big amount of damage will cause us a big amount of pain. But really, most crucially, for the vast majority of us, and I suppose I can't make assumptions about what everybody is living through, but for the vast majority of people, no damage leads to no pain. And that is how we expect to live our lives, is that we are mostly pain-free because our bodies are mostly not going through any damage. So with that sort of view, that a small amount of damage causes a small amount of pain and a big amount of damage causes a big amount of pain, we also assume that the reverse is also true, that if you've got a small amount of pain, it's because there's a small amount of damage, and if you've got a big amount of pain, it's because you've got a big amount of damage. However, we know that that can't be true. So for example, we know that 80% of people who have amputations actually experience pain in the phantom limb. So they're experiencing a big amount of pain from somewhere that there is no damage. So we know that there can't be that direct link between damage and pain. And so you can have a small amount of damage causing a small amount of pain, or a big amount of pain, a big amount of damage causing a small amount of pain, or a big amount of pain. But most importantly, and this is what's happening for patients we look after, you can have no amount of damage causing a big amount of pain. And so the question is, why is that happening, and how can we help? So the reason that that's happening is because of the way that our brain is wired. And so in our brain, we've got this thing called the virtual body that sort of links each of our body parts to a part of the brain that is sort of responsible for experiencing things for that part of the body. But what information is organized in there, and obviously you all know I'm not a neurologist, so I'm talking about this not from a scientific point of view, is that the way these memories are stored is that there's a lot of things that go into that storage. It's not just amount of damage, amount of pain, but also what was happening at that time, what memories, what emotions was the patient feeling. Was that pain something that was new, or had it been happening on a recurrent basis? How were people's reactions to that pain? Did people react kindly, or did people dismiss it? So all of those things are going and being stored in the brain of the patient to be associated with that experience. So if we think about what pain our patients are suffering from, the vast majority of it is basically pain. So we know we've got vessel blockage, hypoxia, ischemia, and the pain stimulus goes to the brain to say, we want oxygen to come to this tissue. And we can think again about small amount of damage, big amount of damage, or no damage at all. And as part of this process, we're happening repeatedly for our patients from a very young age, actually from an age quite often before they even have all, as children, they haven't got all their brain is not all developed yet, and they haven't got all that understanding yet about what is happening and why it's happening and people's reactions to it. You end up leading to this situation where you have central sensitization. So that means that you have increased responsiveness to the painful stimuli in the brain. So the brain is going to overreact to the amount of damage. So that's where you get the big pain from a small amount of damage. So the way that they've explained it in this little book is that the acute pain changes how the nervous and the immune systems work. And we know that the brain, there's plasticity. So we know that in terms of the connections that happen between synapses, in terms of the amount of proteins that are released in neurotransmitters, that these are biological things that can change and that can get formed, and pathways get formed, and that's what memories are, essentially. So that the more you trigger that pathway, the more the brain kind of turns up the volume. So you need less and less physical stimulation to get that same amount of huge reaction. So I showed you the cartoon version of it, but there's obviously very scientific terms of explaining hyperalgesia, allodynia, and neuropathic pain. So essentially, it's about how pain from a stimulus that doesn't normally cause pain. So for example, you can get pain from just touch or pain from temperature. And then so you can also have a particular trigger that should trigger a particular reaction in the brain, but ends up triggering a sort of all-over body pain. And then there's actually the pain that comes from the way that we treat our patients with opioids. And again, this is not my area of expertise, and I don't know a lot about this opioid withdrawal, but I quite like this in this drawing where basically somebody has severe acute pain, they come to the hospital, they have high dose opioids, the pain goes away, then we take off the high dose opioids and we say, here, have some paracetamol. They then have withdrawal from the opioids, and then the pain comes back, and then it builds up again to severe acute pain. And there are lots of papers about this from people who understand the pathways, but we know that actually opioids are not always a good answer. So this is sort of the whole picture about our patients. They've definitely got vaso-occlusive pain. They've definitely, over the course of time, developed a central sensitization, and we are partly responsible for that opioid withdrawal cycle. So what? So what do we do now? Well, from that review, if you want to look at it about the different management approaches, so for example, if you're talking about the opioids, there's different ways of tapering it. There's other things you can use as you come off the opioids. There's opioid rotation where you can use different types of opioids. And then there's all these neuropathic pain medications. clearly, the better we look after the sickle cell, the more we prevent sickling, then the more we can prevent pain in the long term, and there's lots of options here. But then there's that whole psychological and supportive care that will have a massive amount of impact into how people experience pain now, and also, most importantly, how they will experience pain in the future. So if we know that sickle cell disease pain,
it's very clear online.
Sickle cell disease pain is caused by not just the vaso-occlusion, but how people are reacting to the pain, their mental health, the way the emergency medicine works, etc., like the way people sleep. So, for example, there's probably a role for sleep specialists to be involved in how people manage pain. So, if we think about all the different causes of pain in sickle cell, then all of these different people should be involved in helping to manage pain. And from that cartoon, you can see they call it a neurotype, which basically is what I explained earlier about how each pain episode is stored not just as the pain and the stimulus, but also the memory, the emotion, etc. You can actually pull on a memory. It's like this picture where you pull on one thing and the whole thing comes apart. Is you trigger a memory, and then suddenly you've got the whole pain coming with it, or you trigger a particular situation, and then the whole pain comes back. So it's all stored together as a package, okay? They're all linked together. So then the question is, as well as, how can we all work better as a multidisciplinary team to help patients cope better with the pain? But also, I'm really interested in this idea, can we retrain the brain? And of course, we know that we can, because again, with neuroplasticity and the fact that we can the more we do things differently, the more things get rearranged in our brain in terms of new synapses being made. And we know that a lot of this chronic pain is a fault in the system. So there are ways of resetting that. And essentially, it's like fooling the brain, because the brain's already been fooled, and that's what chronic pain is, but the brain's already been fooled because there isn't that stimulus. And this is, again, from that book, this is really opposite examples of the fact that we can't trick our brain, right? So we've got these two lines that are exactly the same size, but depending on which way you make the arrowhead, one looks bigger than the other. Same thing with the other one, these two circles are exactly the same size, but depending on what we put around it, they look different sizes. So we know that our brain is trickable. So how can we do that with pain? And I find this really interesting. So how can you change memories? How can you change belief systems? And what this little book is doing is it's sort of saying, retraining your brain is like saying, well, learning to write with your opposite hand than you're used to. Of course, when you start, it looks terrible, but actually you can train yourself. So what kind of examples do they give? They talk, some of these things will be things that we're used to saying, like mindfulness, etc. But, it's not that helpful to just say to a patient, oh, you should try mindfulness. So what I like about this is the way that it's specific. So take time to learn the subtle flows and tones inside your body. The more good news from your body, the better. So if people train themselves to be very aware of bodily sensations, whether they're good ones or just neutral ones, then that's providing a balance to the one that they're experiencing, which is the pain one. And that pain one will come more in context. So if I go back a slide, and I'll do that. There you go. So that's a bit like that picture about the two circles. So you haven't changed anything about the size of the red circle, but what you've done is you've changed what's around it. So imagine the size of the red circle is the amount of pain you have, and you don't pay much attention to these other bodily sensations when you're not in pain. Then those other bodily sensations, that's the small gray circle. So the pain is quite big in the brain. But if you actually spend time expanding that awareness of bodily sensations, whether they're good or neutral, they take on a bigger space in your brain, and then the pain becomes smaller. Okay? Now, obviously, I haven't done this. I haven't taken a patient and coached them through this and saying, I'm not saying this works. This is just what I've been reading and I'm finding quite interesting, and I wanted to open up to everybody. Anything that de-threatens the sensations you're feeling and supports new possibilities will help bring the pain habit. Tell yourself more beautiful, elegant, and accurate stories. Okay, and there's a little bit more about that, about the words that you use to talk to yourself. So the evidence is that how you move, think, and feel can be relearned. You can train your passive brain to create more safety to switch off pain. And here we go. It's useful to reduce the sensation you experience to really simple descriptive words. Is it hot or cold, moving or fixed, quick or slow, big or small? Pain may become a warm, pulsing area the size of a thumb. So it's sort of describing it in your head to sort of change how how you view it, because it's almost like you're in control of it because you're using the word to describe it. But also play with metaphors that fit you, but also the possibility of change. Avoid pain as an external thing, pain as violence and damage, pain as your fault, you do not deserve to suffer, or pain as a battle. These metaphors rarely happen. Can we teach our patients to think differently about the pain that they're feeling in their body? Try avoid using language that messes with your brain. You can change the pain neurotype with new language and concepts. So the example they give here, this book is not about sickle cell. They don't ever mention sickle cell in this book. So the example they use is slip disc. So that word, a slip disc, sounds really scary. But a disc can never slip. I mean, the disc is never going to physically slip out and cut the spinal cord, for example. So maybe use the metaphor of a disc under pressure or something being squeezed, and then focus on reducing the pressure on how to unsqueeze it. It's much less scary. Obviously, for me, who doesn't experience sickle cell pain and who's not physically in pain right now, it's easy for me to say all this. And maybe it's not possible to do that while you're in pain. But possibly, if this might be something, and I'll be very interested to hear what Ian has to say about this, but possibly if we can work on these kinds of things like language, maybe not when someone's in a full-blown crisis and it's unbelievable and they can't cope with it at all, but maybe as they're experiencing smaller amounts of pain. It's all about making your brain feel safe and turning down the pain volume. So who can do this and how can we do this? Obviously, patients, they're creative, you're unique, you need to experiment to find out what works for you. There's no one answer that's going to fit for everyone. But also, I wanted to open this up to everybody. Can you do something new today? Can we do something new today? Can we learn from each other? So I've got a beautiful picture here of Ian, who is our psychologist. Yeah. But so for example, we have our Zoom support groups. We've got Ian. We've given out some well-being journals we talked about in the support group. But is there a way? Can we do workshops? Is there a way that Ian or other people can train us, the medical team, to talk about pain with patients? Do we have time to do this in clinics? Does it need to be something that we explore outside, this sort of quick clinic appointments? I don't know how much time I got, but the floor is open.
You've got 10 minutes.
Great, that's all I was going to say. I'm really interested in